Well, they changed, the SIOG guideline changed mainly because we had many trials that were published. The previous version was published in 2017. That means that the data came up to end of 2016. So we are now 3 years later, so we had to update because many new trials were published and had to be included. That's the first thing. The second one is that we had more and more in-depth discussion regarding general health and health condition evaluation initially, which is really the key factor and the key point of all the paper. That's why. Well, the main changes, there are two things. We strongly reinforce the fact that we have to evaluate the health status before doing anything, because all what we're doing has to be seen in light of the individual life expectancy. If the life expectancy is long, then age should not be an issue. Age is an issue if comorbidity is an issue, and so we strongly reinforce this, that health status is absolutely mandatory and has to be detailed. So there's nothing really new there, but there's a very strong message about how to do it. The second things are the new trials, and for new trials on localized disease, almost nothing really new. The PROTECT was already available in 2016. So it's active monitoring versus radical prostatectomy versus radiotherapy. For localized disease, we didn't show any survival difference at 10 years. So it was there. The many new things were regarding drugs, and whereas the major new thing is non-metastatic CRPC, which is an artificial disease that we created by using AD2/4 meds. And now we had trials that were not available in 2016, where we know that for patients with a short doubling time, non-metastatic, short doubling time of PSA, there is a metastasis-free survival benefit with 2 drugs, and now with 3 drugs. We don't know yet if it improved the survival, but it improved the med-free survival, it improves the symptom-free survival. So there's something completely new, not related to senior adults, but in general. And we also have new drugs for newly diagnosed M1 disease. We had several before, now we have a lot of new drugs. Not chemo, but mainly androgen pathway targeting agent that improves the outcome. So these are the 2 new things on that, not especially focusing on senior adults, but some of the patients included in all these trials were senior adults, so we had to cover that also. Well, it's not yet level 1 evidence. That it means we don't have strong data to support that. First of all, it's common sense. It's common sense just because the fact is we know senior adults patients are undertreated. That's absolutely evident worldwide. It's also evident that if you stratify by health status, you will know that it's not because you're 80 or 85, you had a perfect health condition. Probably you have to live more than 10 years, even more than 15 years. So it might be useful to stratify that. The question is which tool has to be used. There's still a lot of discussion around that. That's an absolutely good question, and the answer is we don't know yet. We made suggestion. Again, suggestion based on mainly common sense and what is published, but none of them have been formally validated, and that's an absolute issue. Once again, the message is we need to stratify. The unanswered question is which is the best tool to use, and nobody knows yet. Some are available. Some available for chemo, for example. ASCO published and suggested strongly to use a tool that has been validated for chemo. But the tool validated for chemo is might not be exactly the same as a tool validated for surgery or for radiotherapy or for systemic treatment outside chemo. So because the toxicity might be completely different. So which one is the best one? Nobody knows yet, and we absolutely need prospective trials or at least well-designed cohorts to answer that. But the message is use a tool, provided the tool is available, and we made some suggestion regarding the tool that has to be used. Well, once again, it's common sense. If you're absolutely frail, it means, intuitively it means, that you might die earlier compared to somebody that is not as frail as you are. So if frailty is something that is reversible, we might believe that reversing this might improve the survival. I insist on we might believe. It's not completely proven. For example, if malnutrition is a way of design frailty, malnutrition can be reversed. Does this change formally the outcome? Hopefully yes. Evidence-based, not yet. So it might be useful, but we have to prove it. Yeah, probably yes, for at least two reasons. It's very cheap. The initial screening just requires a sheet of paper and a pen. So whatever the country, you almost have access to a pen and a sheet of paper. It almost also requests some interviews at this time, and it can be done by a nurse, provided he or she is trained, so that's absolutely fine. So it's feasible. The next step is, it's also a way to avoid spending money for patients that will never get any benefit from these expensive drugs or expensive management process, and to focus mainly on those who might benefit. So it's the low income or high income countries have nothing to do there. It's worldwide. What you will use after that is different. If you're a low income country, probably you don't have access to very expensive drugs or to very expensive management process. So it's even better to know that before, based on probability of benefit because of your comorbidities condition. We really deserve prospective trials, and some are on the way, but as long as we don't have the results of them, it's mainly common sense, but at least the strong message is age per se is useless.